Good afternoon, SPR. Hi, everyone. How are we doing? Yay. Almost through our second day today. I hope the energy levels are still up. My name is Brittany Cooper. If you don't know, I'm the current president of SPR, and I'm just really thrilled to introduce today's presidential plenary. A personal passion of mine and also a goal of SPR is to build and strengthen the bridge between research and practice. And that's exactly the impetus for today's session and the two speakers that we have. So I'm really pleased to share that we have Dr. Nora Volkow here with us, who's the director of the National Institute on Drug Abuse, which is the largest funder of scientific research on treatment and prevention of drug addiction. She'll be speaking about translational neuroscience, opportunities for partnership and prevention. And then next to her, we have Captain Christopher Jones, Director of the Center for Substance Abuse Prevention at SAMHSA, whose mission is to improve behavioral health through evidence-based prevention approaches. And he'll be speaking about connecting research to practice, building bidirectionality. We also will have time after both presentations for some Q&A, so there's some mics in the aisles. And so be thinking about those questions as you're listening. And we'll look forward to a little bit of discussion. So without further ado, I'll hand it over to Dr. Volkow. Thank you.
Good afternoon, everyone. Good afternoon, SPR. It's actually, I think I was saying, an opportunity for me to actually focus and think about what is it that I think is more salient that we can bring forward to advance exactly the goal of this meeting today, which is science to translation. And that's what I am to do. And it's also a pleasure to be sharing the podium with Dr. Chris Jones, which is actually ultimately at the end of the day, we don't create partnership between both of our agencies, then the science is just going to stay itself limited to publications and never have the impact that it should. So I do very much appreciate him being by my side here. I guess that overall we have at NIDA, and I've been directing NIDA now for 21 years, is emphasizing the importance of prevention. And I don't need to bring it up to this group here, but prevention is not something that captures the imagination overall of academicians necessarily, or even politicians. And so it has been neglected. And I think that as we look at where the circumstances place us right now, neglecting it is coming at the cost of hundreds of thousands of lives because of the the opportunity that we would have had of preventing them from the overdoses. I think that the overdose crisis does bring to light why the importance, how crucial it is to do prevention. And these are the numbers up to the last 12 months up to November 2023. Similar numbers up to December 2023, but overall, we know that more than 108,000 people have died on 2023 from overdoses. And this initially, though, had started with overprescription of pain medications. And so in that respect, the perspective of people in administration, on academicians to address the crisis was let's develop better guidelines for how to use opioid medications to prevent people from overdosing. But currently, as you look at the contribution of deaths by the different categories, natural and semi-synthetics correspond to that exactly of the opioid analgesics. And that is less than 10% of the overdose mortality right now. And so 90% of the rest of the overdose mortality is not per se linked to the opioid medications. And that forces us into thinking about what other strategies we need to implement. Clearly, one of the main strategies, which is of course fundamental, is to expand treatment for opioid use disorders, expand medications for opioid use disorders, expand access to naloxone. And when you think about expanding access to medications for opioid use disorder or expanding access to medications like naloxone for overdose, I always sort of feel like, well, they are described as treatments, but you could also, depending on what outcome you are looking for, you could also describe them as prevention interventions. Treating someone with buprenorphine, methadone, naltrexone for an opioid use disorder is a prevention intervention against them overdosing. Providing expanding access to naloxone is a prevention intervention from preventing someone from dying from an overdose. So those are strategies, whether one calls it treatment or prevention, actually does really, at the end of the day, doesn't really matter. But it does set up a very different narrative. Also, as we're starting to observe, and you see this, actually the contribution of overdose deaths by the main one, of course, is the culprit is fentanyl. But then you have cocaine and psychostimulants, and you see that psychostimulants, if you take both of them, are contributing like 66,000. Now you say, well, Nora, those numbers don't add up. And they don't add up because many of these overdoses are counted more than once. So if someone dies with cocaine, at least 75% of those overdoses had fentanyl. So that's why you have the numbers that go way above 109,000. And the same thing with methamphetamine, where also the majority of the overdoses are associated with opioids. So then that whole issue of the intervention that gives medications for opioid use disorder starts to be insufficient, because if you have a cocaine use disorder, you actually are not going to necessarily at all benefit from these medications. It wouldn't be necessarily indicated at all. And this had, one of the things that it has done is it has expanded the demographic characteristics of people that are at risk for overdosing. And so then it was started to notice it's polysubstance use disorders, or people that have cocaine or methamphetamine use disorder that are now at risk for overdosing, because those drugs are frequently laced with fentanyl. And more recently, we have seen a shift on the way that fentanyl gets into the country, predominantly as illicitly manufactured pills that are disguising fentanyl. And it is estimated that now the majority of the fentanyl that comes into the country comes now in these illicitly manufactured pills that look like sort of a Vicodin or an OxyContin or a benzodiazepine. And so people that may be occasional users actually are now at risk for an overdose, because even though they don't have an opioid use disorder, they may get their hands on these pills that are sold in the web at lower prices than the real stuff, or that they may be given these pills by a friend or a neighbor. And so how does that diversify the demographics? Well, all of a sudden we know that older people who are more likely to have pain, more likely to not be able to sleep, are now at risk for overdosing. And not because they are seeking out fentanyl, but because they get their hands, unbeknownst to them, on one of these prescription pills. And two, what we are also observing is teenagers who also tend to use psychotherapeutic drugs. They don't necessarily seek out fentanyl or necessarily seek out heroin, but they do seek out psychotherapeutics, where it is a psychotherapeutic drug, say, for example, to actually mix with alcohol, which is a way to actually, they do in parties to get high, and they can mix an opioid or alcohol or to help them sleep. And so what we've seen that during the transition of 2019 to 2020, which does correspond to the COVID pandemic, when the massive amount of fentanyl came into our country, we saw close to a tripling in overdose mortality from fentanyl at teenagers. And that forces us to rethink our strategies beyond that classical one of let's provide with treatment, and yes, let's continue to, it doesn't mean we shouldn't, it's a priority top, but it's not sufficient. We need to address here how crucial it is to address prevention. And not just prevention in terms of preventing overdoses, but prevention in terms of helping people prevent them from taking drugs that ultimately could cause their death. And that becomes a much more challenging than the simple strategies that we could delineate at the beginning of the epidemic. Now, in targeting interventions for this group of individuals, the teenagers, actually, we have, NIDA has been funded research for decades, and we have focused very much in children and adolescents. And this is because most of the evidence indicates that this is the period of greater risk, where exposures that actually are going to have a long-lasting impact in the individual that may make them vulnerable to taking drugs and becoming addicted. And so what have we learned about all of that? Well, we have learned that, first of all, and it does inform directly into prevention, first of all, the period of childhood and adolescence is a period where you have the fastest changes in the brain. And in the upper figures over there, I'm just illustrating different metrics of of how how the brain changes from early infancy into late life. And when you are born, your brain is basically not fully formed, but its size and volume is almost close to what it will be when you become an adult. It will grow, but the rate of growth per se, just in terms of volume, is not the main change that it does. The main change is it basically generates the connections. It's like when you have a stone and you want to generate a sculpture out of it, you actually have the whole volume over there and you're bringing it up, the pieces that you want to get out in order to get that shape. Well, that's a good way of looking at our brain. So as a result of that, if you look at it, there are different metrics. Our volumes don't change very much, but they start actually reach volume size very early on. But on the other hand, the gray matter volumes, the white matter volumes, the white matter which leads to the connections actually take much longer. And many of these parameters are not fully formed in its adult version until we are in our mid-20s. And then they become more or less stable. But this is the period of very fast growth that makes actually children and teenagers particularly vulnerable to exposures in life. And this is good and bad. It's good because it allows them to actually mold their brain to what they are experiencing on their realities. But it is bad if they get exposed to, for example, an adverse childhood experience that is very traumatic, or they get exposed to drugs during early developmental stages, because it's going to directly impact the brain in a way that will have a long-lasting cumulative effect. And so it's not surprising that this period of transition between childhood, adolescence, and young adulthood is when the mental illnesses start to emerge. And all of them, is not that it's very clear-cut that substance use disorders start much later than the other ones, or that schizophrenia starts earlier. All of them share this developmental stage of great vulnerability. And I do want to highlight it because a lot of our interventions, we like to see prevention for substance use disorders. I mean, the reality is prevention for proper mental health, prevention that can provide resilience to these children and adolescents, both for substance use disorder and for mental illness. Because one of the factors that increases vulnerability for substance use disorder is, of course, mental illness. An early manifestation of mental illnesses may appear by the need of a teenager to take drugs as a means of auto-medicate. So the science tells us, yes, prevention should be targeted to providing resilience across the well-being of that individual. The other thing, if this brings forward, is we do know, of course, that addiction has a genetic component, and we know that because it runs in families. So we know that, and this has been known first, identified for alcoholism, now alcohol use disorder, and then it has subsequently been studied for a wide variety of addictions. And the same thing has been reported for mental illnesses. We do know that all of these diseases of the brain, neuropsychiatric diseases, have a genetic component. So there has been a lot of research. We funded a lot of research to try to understand which are the genes then that make someone vulnerable to addiction. And the research has been looking at it, well, what are the genes that make someone vulnerable to tobacco or alcohol or cannabis or opioids? And researchers have identified this or that gene, and overall, what is right now consistent, and the same thing with behavioral disorder, is that there's not one gene, but it's a multiplicity of genes that actually, in combination, provide a risk. So that's number one, and we call that, now we describe that as, if we want to establish what is my risk, they will look at my polygenic risk score to determine how many of those multiple genes that have been associated with higher risk do I have. But the other thing that has emerged as also the main finding is that these polygenic risk scores don't predict a specific cannabis use disorder or opioid use disorder. They predict a vulnerability for addiction. And that is a much higher effect size in terms of the prediction ability than it is to just predict a particular one. And there are many more genes linked with that genetic vulnerability for addiction than specific genes that are associated with a particular substance. So this indicates to us, as we're thinking even about the genetics, that it is not just targeting at all one addiction, which wouldn't make sense at all in children or adolescents or your adults, or even sometimes among adults overall in general. But the other aspect that this data shows, and this is the largest study that we've ever seen, is that if you look at it, this implies different factors that are associated with these polygenic risk scores. And if I can make this thing, I don't know, this is impossible, guys. You're going to have to count on me. You see that horizontal line, basically, and there's some, and it has dotted lines up and down. Well, the ones that are up are those symptoms that are associated with the polygenic risk score for addiction, the main one for addiction, which is the most prominent one. And what's interesting is that many of the symptoms of mental illnesses, behavioral disorders, are associated with it, particularly internalizing symptoms of anxiety, of depression, also correlate with this polygenic risk score. So what the science is telling us is that it is not clear distinct entities that are emerging, but that you are probably having a vulnerability that may manifest itself in anxiety, that then may make you more vulnerable to smoking cigarettes, because that will temporarily decrease if they are anxiolytic. Nicotine is anxiolytic, provided that you're actually not on withdrawal. So it is, and for the perspective of prevention, again, highlighting why, when we're doing prevention intervention, how crucial it is that we do screening for not just the specific substance that we're thinking, but for behavioral mental illness. And the final one that we see also the commonality for all mental disorders in general, and including substance use disorder, is the adverse childhood experiences. And overall, we do research, of course, on genetics and also on epidemiology. But if you compare the effect sizes that you get in terms of increased risk, if you have the polygenic risk score for addiction versus if you have the counting of the adverse childhood experiences, you can see a dramatic difference in your ability to predict who is at risk. So if I take a genetic score overall, and again, now there are claims that there are gene tests that basically are, what they are looking is ancestry, it's really not risk, but they are being sold as such. But if you look at the best in terms of like the 1 million subject study, and you do the polygenic risk score, you may be able to predict a 30% increase in risk, 30%. Now look at those numbers, odds ratio for illicit drug use as a function of the adverse childhood experience score. So your risk is tenfold, not 30%, tenfold higher. So highlighting, and this is again, not unique for substance use disorder. So we know that adverse childhood experiences increases the risk of internalizing, externalizing disorders in substance use disorder. So, and keeping this in mind is crucial, of course, for prevention and also for treatment. So what have we done in terms of the science? Well, we know that these adverse childhood experiences are fundamental in the vulnerability. And we funded a lot of very good preclinical research, predominantly in rodents, that actually has identified why is it, what are the neurotransmitter systems, the chemicals that are disrupted under stress conditions. And the stress conditions also are not equal one to the other. There are some stress conditions that actually have more deleterious effects than others. So it's not necessarily the same to have neglect as to have, for example, physical abuse. And understanding the uniqueness is, of course, relevant overall. But what we do know now from those preclinical studies is that now we have the tools to investigate specifically, well, in animals we could manipulate, but in humans, of course, we cannot manipulate someone, nor do we ever want to put them on a stressful condition. But we have the tools now to do that in a prospective design and understand what happens to the brain and the behavior of those children as they grow from infancy into adulthood. So one of the two of the main projects that we've prioritized at NIDA, and we've done this in partnership with several of the other institutes, including the Alcohol Abuse and Alcoholism Institute and the National Institutes of Mental Health, is to launch 2 large longitudinal prospective studies that one of them, which was the first one, was launched in 2016, the ABCD. So it has been out there for 8 years already. And it started recruiting children when they were 9 to 10, and we've been following since then with a retention rate of over 90%. And these children have been periodically evaluated, including brain imaging, with a deep phenotyping for adverse childhood experiences and other social determinants of health. And it has been so successful that last year we initiated one similar, but starting in infancy. And that study was just launched last year, so that's the HPCD. I don't have per se much data. But out of these studies and preceding it through the pilots, we have come to realize, for example, what you see to the left, this is in green to the right, and in purple, the lower one on the HPCD, that the children whose mothers during pregnancy were stressed and have low social support systems, actually those infants have reduced volumes in their white matter and in their gray matter. They were exposed to the stressor through the mother in the pregnancy, and that has already a lasting effect in parameters that are very consequential in terms of how the brain develops, the volume of both gray and white matter. And to the right, you see a series of studies, an example of a series of studies that have shown that by looking at brain volumes and cortical thickness and white matter connectivity, and looking at how different determinants, social determinants influence them, they have all gotten concordant information that indicates that if you are a child born into a family with low income, your gray matter, your volumes of the brain are going to be smaller, and your cognitive performance is going to be worse, significantly. And not all of the areas of the brain are equivalently affected by these differences in income. Some of them are more, like what you see there on the oranges. The yellow ones are the areas that are more significantly affected. The superior frontal cortex, which is fundamental and crucial in regulating many operations. The middle cingulate gyrus of the brain, which is also fundamental in risk for addiction and also implicated in depression, and the temporal lobe. So these are important studies because they are giving us light on an understanding of how income or other social determinants of health influences these developments. And through research like that, for example, one of the papers documented that one of the factors that contribute significantly to the differences in volume and cognitive performance by race and ethnicity is driven by economical inequalities. So, and from the perspective, because we are right now here on a meeting on prevention, how do we use that data? And this has now also, we are encouraging researchers, by the way, all of the data on ABCD, HPCD is open access, and it provides actually the statistical packages that will help you explore it, and we welcome that, and we are funding researchers to get funding in order to be able to take advantage of these data sets. And this is one of the studies that came out that actually was looking at, since it's for the ABCD, it's close to 12,000 children. They asked the question in states all over the United States, and they said, well, we know that poor income is putting stress in the families, and they are doing much worse. Well, but if we take advantage of the states in terms of they differ, some of them are high-cost living, others are low-cost living, and some of them are not just high-cost living, but they may have bonuses, cash bonuses that help the families. And so they compared the different states to see how that influenced both the brain of the children as well as the emergence of internalizing symptoms, depression and anxiety. And what they showed, which is in the histogram to your right, is that if you come from a high income, it doesn't really matter, and those are the grays in terms of internalizing symptoms, whether you have you're coming from a high income or a high cost of living state or a low cost of living, or you come from a state that is a high cost of living and it has cash bonuses or not. It doesn't make a difference. But it does make a difference is when children that are coming from low income families and that live in states that are actually are basically high cost of living, in the states that actually have bonuses, there it does make a difference, and it significantly attenuates the emergence of internalizing symptoms. And they also reported in terms of volumes of the hippocampus. So it does make a significant difference. And this is a policy base. Similarly, through research in smaller groups of subjects, other investigators have actually done interventions where they actually provide cash, which is what you see to your left. This is a study done in 1,000 infants of poor income families where they divide them randomly. One of them got $330, which was the intervention, and the other $20. And they let the family use the money whichever way. And then 1 year later, they did an EEG to assess how the infants were doing. And those that got economic support actually did significantly better on parameters that are measured through electroencephalography that are linked with higher frequency activity and better cognitive performance. So the evidence out there, yes, providing resources that can decrease the level of stress to families so that they can properly support their children is a significant and effective prevention intervention. And so have many other studies shown that ultimately, yes, we know what to do with evidence-based prevention intervention, decrease risks, enhance those resiliency factors. And we know that there are many ways that we can intervene. Individual, family interventions are very consequential. And so are communities and involving the schools. And so there's a whole variety, and the evidence is out there. I mean, we may need more evidence-based intervention. I'm not saying that we don't, and particularly an aspect that we want to keep an eye on is how easy or difficult are they going to be to implement and sustain, and I think that that's something that we have to keep our eyes on. But this evidence-based prevention, regardless, are not being implemented, and that's an issue that is very, very frustrating. So how many children could potentially, or adults could potentially have benefited from an early prevention intervention, we'll never know, because we actually don't even know how many of those individuals that would have benefited from a prevention intervention, whether it was universal or tailored, would have benefited. And this is an area that we require more information. We need to create, just like we have a cascade of care for HIV, and we're currently doing one for opioid use disorder, we want to have a cascade. We should develop a cascade of prevention so we can highlight where there are gigantic gap areas. We all know the song. I mean, why is it that we hear why evidence-based prevention is not implemented? There's limiting funded, grant-based, there's not sufficient workforce. The evidence-based programs are not just universally available, no data tracking system. There's a multiplicity of factors, and my perspective on all of these, we can keep on repeating them ad nauseam. That's not going to advance our cause. So we need to target it and do it in a way that is systematic and with very specific ways of documenting the outcomes. So we are, of course, continue to fund our research in terms of prevention, and this is one of our newest initiatives where we are expanding. NIDA had been predominantly focusing our studies on prevention in children and adolescents, and now we're expanding that into young adulthood and other other ages in life, and two, trying to make it actionable interventions that can help us address the social determinants of health in ways that can be used by a system. And again, I'm going to reiterate, and sustainable. So amidst all of this frustration in sort of viewing that we are missing a terrible opportunity that is costing the life of many, many people, not just in terms of the fact that they are dying, but it's basically disrupting their prospects, and that we didn't even speak about it. And yet we have neglected it. I mean, and that's where, despite the fact also that there are evidence-based prevention, and we always speak about prevention is like tenfold at least more effective than treatment. But yes, and we repeat it, but it doesn't translate into anything. So in order to try to tackle it and to revitalize it, actually at NIDA in partnership with SAMHSA, and so that's why I say it's great to have Chris by my side here, and very much led by Amy Goldstein and Carlos Blanco at NIDA. We actually have requested at the National Academy of Sciences and Medicines to do a report on prevention to help us identify what are the best practices, what are the funding needs and strategies to get them, because right now all of it is segmented this and here, and there are short periods of time, so that is not driving the incentive of anyone to go into training onto that space. What are the research gaps? Are there opportunities in science that we can do that can make some of these interventions more effective, or also less expensive and easier to implement? And two, importantly, I've learned now that I've been at NIDA for 21 years that perhaps the most consequential thing that we can get out of all of this science is to drive policies, but drive policies that have teeth, because policies without teeth are basically useless. So how can we drive science to actually change policies in the ways that are going to prioritize prevention and are going to actually allow for the resources that are necessary to sustain it? And I want to also emphasize that this requires the partnership with all of us. And certainly for us, SAMHSA has been a fantastic partner, but so has been CDC. And I think that all of you many of you who are doing the research, or some of you who may be practitioners, creating networks where we can actually bring the data back and forth between everyday practice and what our scientific questions are, is crucial to coming up with solutions that are relevant to the realities. And with that, I want to thank you for your attention.
Thank you. Captain Jones, take it away.
Well, thank you very much. Appreciate your remarks, Nora. Always great to share a stage with you, and appreciate the longstanding partnership across SAMHSA and CDC and FDA and HHS and all the various other places that we've worked together. And I love this mix of a talk because it really does provide us the opportunity to take that in the weeds science and say, to what end? How do we leverage the latest understanding of brain science, neuroscience, policy, program? We have the mechanism, the vehicle in which to operationalize that in communities. And it is a great honor to be able to do that. But it also means that we have to have a very tight relationship in sharing information. And so those papers that are done with NIDA funding don't sit on a shelf, but we bring them to life. And I want to thank Ingrid Donato from my team and Amy Goldstein as well, as really the engines that have been continuing this partnership and collaboration across our agencies. And I am definitely not good at this clicker, no matter how hard I try. So I am going to present some data, but hopefully contextualize it in a way that is helping to drive our program activities. The one thing I'll say is that I was a little depressed with Nora's brain development trajectory, because I'm like, oh, I'm sort of over on the right-hand side. It's all downhill from there. And I had a moment today, I was cooking earlier with my daughter, and it's just like a complete, like, my brain is not working. I was like, can you please hand me the 2-cup glass pouring thing? And she was like, the measuring cup? I was like, okay, so I'm definitely in the right spot in my brain trajectory development. But as Nora so eloquently said, we really are dealing with an unprecedented situation of overdose in the country. And this takes a look back, following back to 1968 through 2022. And we see that while a lot of media and others have started paying attention to this issue in the last 5 or 10 years, this has been growing for some time. And for you who've been working in the drug space for some time, this is not news. But certainly it escalated during COVID. And we continue to see that it is very uneven across the country. So recent news reports on the provisional 2023 data show some small declines nationally. But when you start to look at this at a state level, you see that about half of the states are continuing to see either very small declines or continued increases in overdose. And if you were to look in at the county level, you would even see greater variability. And so, there is a lot of opportunity in research to understand what is driving this. I mean, certainly some function of the illicit drug supply and a westward shift of fentanyl into Western states is a contributor here. But even within states, given the variability, there are so many opportunities to really unpack What contributes there? How do social determinants connect in to risk? ACEs, the many things that Nora talked about. The other piece is that we are dealing with a synthetic drug market that is driving the overdose deaths. This is from CDC's Suitors data, which allows us to get a little bit more granular understanding of the particular drugs that are involved in overdose deaths. And from their 2022 data, less than 4% of overdose deaths in the US do not involve opioids or stimulants. The vast majority of that is illicit fentanyl, synthetic opioids, as well as methamphetamine and cocaine. And often that is when both of those substances are mixed, as Nora mentioned. But when we think about in the overdose space, like really where are we focusing our efforts? 96% plus of the overdose deaths are driven by opioids and stimulants. We've also seen shifting epidemiology of overdose and who is impacted. And I think this really connects into the issues of social determinants, longstanding poverty, disinvestment, bigger P policy pieces that contribute to changing demographics. Communities of color have been particularly impacted. And in fact, when we saw the 2022 data from CDC, primarily non-Hispanic white populations, when we look at race ethnicity, experienced the declines in 2022. Other populations continue to see increases. We also saw that among some age groups, in particular as we think about prevention and needing to challenge how we approach prevention in new and innovative ways, is that 12 to 17-year-olds are continuing to have increases in overdose deaths, whereas some of the young adult groups have actually seen small declines. And it really does challenge us to think about how are we approaching overdose prevention within the context of broader substance use prevention, expanding access to naloxone, opioid overdose reversal medications, raising awareness about counterfeit pills that are pressed with fentanyl. We have work to do to reach that population in ways that are accessible and resonant with those populations. And my take is that we're really dealing with a situation that is more dangerous than it has ever been. So whether it's somebody who's initiating or experimenting with substance use for the first time, or somebody that has a longstanding substance use disorder, we see a very toxic, potent, unpredictable illicit drug supply, which increases risk across the board. That's for opioids, but also the emergence of designer benzodiazepines, designer stimulants or synthetic stimulants, cannabinoids, synthetic cannabinoids. We really do see this proliferation of synthetic substances that are all too easy to circumvent Controlled Substance Act, international controls. It's easy to make a small modification, then all of a sudden that substance is not illegal until we actually catch up with our regulatory controls. But the other piece as we think about prevention is that the usual suspects are also ever present. And in fact, they are also changing. If you think about different methods of cannabis consumption, high potency cannabis products, waxes, butane hash oil, concentrates, there's a proliferation of products that are exposing developing brains to things that are highly potent, and they have impacts. We saw changes in alcohol policy during COVID, which can lead to changes in community norms about acceptability of alcohol use. You can order it, you can take it out, it's more open in public as a result of changes in COVID-related policies. And then, of course, nicotine and vaping is something that we constantly hear from our state and local colleagues that, again, this proliferation of vaping in communities, which, again, nicotine, highly addictive substance, it's priming the brain, and it is one of those first go-to substances among individuals. So we want to keep our focus on overdose and preventing overdose, but also maintain the fact that this is really a polysubstance issue. And with prevention, we need to think about what are the substances that people are likely to initiate with. And this is just a slide that I like to include, I think just underscores the seriousness and the sense of urgency to this issue. So this is essentially the percent of deaths for any cause that are due to drug overdose by different age groups. So about 1 in 12 people, 12 to 17, die from an overdose for all the reasons that they die. That quickly goes to 1 in 5 among 18 to 24-year-olds, 1 in 3 among 25 to 34, and 1 in 4, 35 to 44. So we often think about, cancer, heart disease as leading causes of death by number, which is true. There are many more deaths due to cancer and heart disease than there are overdose, but that's typically in older populations. So when we look in younger populations, it is injury and violence and oftentimes drug overdose. But I think if you went to policymakers and others and said 1 out of every 3 deaths among 25 to 34-year-olds is an overdose, I don't know that they would necessarily recognize that. I think they would recognize that it's a problem, but I'm not sure that they would recognize that it's that frequent as to why people die. So when we're thinking about our prevention work, we obviously have all of the warning signs and the concerns around rising overdose and proliferation of synthetic substances, but we also have some things to be proud of and that I think can motivate us to continue our work. When you actually look at youth substance use trends over time, substance use among young people has been going down. It's consistent in the YRBS data. When we had trend data in NISDA, it was consistent in NISDA, and certainly in monitoring the future data, which I have here from, funded from NIDA. And this looks back just over a 20-year period, and we see that really across a variety of substances, we have seen declines in substance use, even, sort of continuing the declines that were found during the COVID period. So those are successes. We should understand what is driving some of that, because we know that can help inform our prevention work. But at the same time, we also recognize this sense of urgency about overdose. And so we're often pitted of, we've got to do one or the other. And my perspective is that we can do both. We can maintain a focus on the urgent issue of driving down overdose deaths while also being committed to looking upstream and implementing upstream preventive interventions to reduce substance use and reduce progression of substance use. As Nora mentioned, and I really appreciate that they're funding studies that are not just focused on children and youth, that there really are opportunities for prevention across the lifespan, and NISDA data help us tell that story. When we look at the 3 most commonly used substances, nicotine, cigarettes, alcohol, and marijuana, we see that there is a large percentage of people who are initiating use of those substances in the past year that are not youth. Young adults and even older adults are initiating those substances for the first time. So there are opportunities for prevention. The approaches to prevention might be different in some cases, but certainly there are opportunities for prevention across the lifespan. And we also see, if we sort of flip how we look at the data and look at prevalence of non-use, the vast majority of 12 to 17-year-olds, at least according to the NISDA, are not reporting substance use in their lifetime, in the past year, in the past month. That's a good thing. Like, we should lead with a strengths-based approach and say, although you may think it is highly pervasive that all of your friends are using substances, data would suggest that that's not necessarily the case. And that's, if you look at smaller studies of schools, researchers have consistently found that reported rates of substance use are much lower than the perception of substance use among their peers. And we know that that context and that norm in those networks is an important protective factor or risk factor. But when we look at non-use among young adults, 18 to 25-year-olds, we see that it drops very quickly, especially for lifetime use. So over half have used alcohol, cannabis, nicotine products in their lifetime. It's less for past year and past month, but it does underscore the opportunity that we are missing something in prevention if we're only focusing on youth. We want to continue and set those folks up on a trajectory. But if you think about young adults, they're transitioning from a home-based environment. They're in a new social network. They are, exploring independence. Some of them are in college. They're finding jobs. They've got other stressors that are coming into their lives. And so you tend to see substance use escalate, either initiation or escalation of substance use. And so whose job is it, if it's not prevention's job, to be focusing on this population? And I'll get on my soapbox for a minute, because I often think we set up a system where prevention focuses on reducing initiation, and then you've got the treatment system over here, and you're on your own until you need treatment if you've already initiated substance use. And I think there's lots of opportunity, one in the research space, to understand what do we do here, because that's probably the area where we know the least. We know a lot about treatment. We know a lot about preventing initiation. But there are effective interventions, and we know because of other risk factors like mental health conditions, other economic stressors, that addressing those in that population can also reduce progression of substance use. So I think that is a real area where we need more research, is focusing in that space. The other part that drives our work is, again, trying to look at this from both sides, the urgency of the overdose crisis, where, again, there are many missed opportunities to save lives. CDC Suitors data show that about 20% of people who died from an overdose had evidence of naloxone administration, even though 43% of the time somebody was there. Somebody could have administered naloxone. There are many missed opportunities, but we are dealing with highly potent, fast-acting substances like fentanyl, so naloxone needs to be readily available in those situations so it can be administered. But we also see that there are many opportunities in the sort of more traditional prevention interventions. NIDA does collect questions on protective factors or exposure to certain types of preventive interventions or prevention programming. And we see that we do pretty good when we ask questions of among 12 to 17-year-olds, did you have somebody that you could talk to about your problems? 93% of 12 to 17-year-olds said yes, they did. That's a good thing. I mean, I feel for the 7% who didn't have that, but that's an addressable gap. When we look at the question of, did your parents let you know they were proud of you for something you've done in the past year? 80% said yes. That means 1 in 5 12 to 17-year-olds had not heard from their parents in the past year that they were proud of something that they did. Again, we got some work to do on like parenting skill programs, positive parenting. We start to drop off when we see, like, did they see or hear something around substance prevention messaging outside of school? About half of kids said they talked to their parents about dangers of tobacco, alcohol, or drug use. And then when we get into like the programmatic stuff, problem-solving, communication, self-esteem skills, violence prevention, programming, which often has spillover effects for substance use, or participating in a substance use program outside of school, we get to really small numbers. And I think this gets to Nora's point that there are evidence-based interventions, but there is this mismatch of actually implementing them in communities. And Nora mentioned this as well, the intimate connection between substance use and mental health. And I think this is really important as, one, we think about the research and sort of the bidirectionality of mental health and substance use. It's not one direction. It may be that somebody's experiencing anxiety and so they're using substances to cope, but we also know that substances can exacerbate or contribute to mental health challenges as well. But regardless of how you cut it, adults or kids, across all substances, we see that individuals who are struggling with mental health challenges have higher prevalence of substance use. If you looked at substance use disorders, you'd see the same thing. From the prevention side, how do I use this data? Well, there are a lot of shared risk and protective factors between mental health and substance use. And I try to use it sort of from an advocacy perspective. I say, okay, if you're a congressional member who cares about mental health, here's why you should care about the work we're doing in CSAP, the substance use prevention work, because many of the interventions can have a benefit to both substance use and mental health, in addition to many other health risk behaviors. So at SAMHSA, we're approaching this work in a holistic way, guided by HHS's overdose prevention strategy, which does include primary prevention as a component of that, harm reduction, evidence-based treatment, and recovery support. And then SAMHSA released a strategic plan about a year ago now, and preventing substance use and overdose and in promoting resilience and emotional health for children, youth, and families are largely where we see much of our prevention work. But when you think about the interplay of substance use and mental health, or shared risk and protective factors for substance use and suicide, we see ourselves in that priority area. Certainly workforce is a challenge in the prevention space. And then how do we also integrate prevention into the medical system? Because much of prevention happens outside of the medical system. So as we think about integrating behavioral health and physical health, we also have to think about how are we building in the ecosystem of prevention within those models, including the financing side of that to support preventive interventions. Sarah Potter will be happy that I mentioned financing and prevention. So at CSAP, we've taken this data-driven approach to really say, who do we want to be? And where are we trying to go as a center and as a field? And I think our vision really reflects the fact that it's not at the end of the day about the substances. It's about how are we changing the context in communities, in families, so that people can be healthy and thrive. That's our vision. We get there by supporting broad-based substance use prevention efforts. I also thought it was very important that as we thought about who we are as a center and how we want to engage with the field, to be very explicit that it's not just about preventing initiation of substance use. That is an important goal of our work, but we also aim to prevent the progression of substance use. Because somebody has initiated substances, it does not mean that you are predestined to have a substance use disorder. We can do things along the way to reduce that risk. We also want to prevent and reduce substance use related harms. And this gets again to the overdose piece. There are many people who are overdosing who do not have a substance use disorder or an opioid use disorder. So what are we doing? That's prevention space to be operating in. I'm not going to bore you with this, but we have strategic priorities that help organize our work. They're beautiful. We also have guiding principles that are data-driven, innovative, community-informed, grounded in cultural humility, focused on health equity, and inclusive of social determinants. And that really is infused throughout all of our strategic priorities. So I love it that Nora and I did not coordinate the development of our slides, but we have come to the same conclusions with respect to the data, as well as with respect to the drivers. And social determinants of health, adverse childhood experiences, and we both had a slide that we both stole from CDC about ACEs, but I think it's important that these are the traditionally defined ACEs. But we now understand from science around toxic stress that there are many other experiences or events that an individual can go through in early childhood or in childhood and adolescence that play out very similarly physiologically to the more traditionally defined ACEs. I mean, when this was originally done, CDC and Kaiser in the mid-90s, we didn't have things like cyberbullying, right? How does the internet interplay with risk for substances? We weren't thinking about community violence, exposure to firearm-related violence in communities, a impending sense of insecurity, food insecurity, housing insecurity. So all of those things, I think, fit into the idea of ACEs, or things that exacerbate and perpetuate ACEs. And as we think about our work, one of the things that I really have been trying to stress with our prevention counterparts in the state and local level is taking this broad view. So we have the science that says these are very strong contributors to risk. It doesn't account for all risk, but as Nora said, when you look at ACEs, it is a really large part of the risk. And we did research when I was at CDC that shows if you have ACEs, especially multiple ACEs, you're more likely to initiate substance use early, regardless of the substances we were looking at. So not only do you have an increased risk for using substances overall, but you're also initiating early, which we know can influence risk down the line as well. So we've been trying to say, let's take a broader view, because if we're not addressing these things, we're really missing critical opportunities for prevention. But we have to look at this across the social ecology. So a lot of prevention fits into the individual level, and we focus a lot on programs that are provided to individual people to do something: resilience, problem solving, life skills, raise awareness. Those things are all very important, but that is often what people think prevention is. And I think we have a critical opportunity and really an imperative to say that is a piece of it, and it needs to be a part of the ecosystem. But we got to think about the relationships in families. How do what's going on with parents or caregivers influence their kids? I mean, it gets directly back to ACEs, and it gets to stress, right? So if parents are stressed about making ends meet, they don't have the money to have stable housing, they don't have the money to have a secure food source, they don't have transportation, that plays out in stress in families. It plays out in child maltreatment, child abuse and neglect. It could play out in intimate partner violence among parents, so kids are exposed to that violence. So it's not a very long path to see how that family side can contribute to individual level risk. So we have to think about how are we strengthening and supporting families and positive parents and parenting. We have to look at school and community. So we also know that people and families operate within the context in which they live. So what are the norms within the communities? What are the supports that exist within the communities? What are the opportunities for lifting people out of poverty, create opportunities for jobs, for housing, for other supports that we know are critical. And then ultimately at the society level, how are we thinking about big P policy to affect social determinants, to reduce risk for adverse childhood experiences? And I think that really challenges us because that is an uncomfortable place for a lot of prevention people who are prevention program folks to be operating in, because big P policy is hard. And you got to be able to navigate the politics of those situations. But I think it is important that we have to do it. And we need better research to help make the case for why those other parts of the social ecology are equally important to the individual level interventions. So at SAMHSA, we have a lot of programs that exist in communities. I will say that our discretionary budget is about 1.8% of SAMHSA's budget. So you'll see a lot of dots here, which are individual grantees, but oftentimes it's not a lot of money going to those dots. It's definitely not money to evaluate what they're doing. And I think that's where we have such an opportunity to partner with NIDA, to partner with researchers, because we want to understand, and the communities want to understand, we did these things. We followed the strategic prevention framework. We understand what's going on in our community. We made a decision that these are the things that we think will make a difference. And oftentimes, at the end of the day, they don't really know. They have some outcome measures, some process measures, but there is a need for partnership with researchers to evaluate. And it's such an opportunity because it's happening in very different communities, often in very different communities than much of the prevention science base is built on. Some of that research is fairly old at this point, and it was studied in a different time in certain populations and not other populations. And there is a real need to study, in a sense, these natural experiments that are happening in communities. Our largest financial program is the Partnership for Success. We fund both states and communities, and it is our broadest discretionary program. It really focuses on building that prevention capacity and infrastructure in communities, and communities tailor what they're doing based on an assessment of the substance use trends and drivers in their community. They focus on interventions at the programmatic level, like life skills, good behavior game, but also social media, public messaging campaigns, policy change at the state or local level as well. So it's a broad range of things that could be studied. And here's the second program is our Stop Act program, which is like outrageously small funding, $60,000. But it's supplemental funding to drug-free communities, either current or former drug-free community coalitions, which the coalition model essentially says you bring in 12 sectors of the community and you look at the social ecological model in a sense through environmental strategies, sort of the built environment, through individual raising awareness, the policy piece. So again, we have a number of programs here that are implementing various approaches, alcohol outlet density policies, messaging campaigns, other approaches to engage young people. This is specifically focused on underage drinking. So again, ripe opportunity for evaluation research, in particular among different communities, rural communities, different race ethnicity composition in communities, tribal communities, and others. We have a specific tribal program called Native Connections. It's a shared program between our Center for Mental Health Services and CSAP, which focuses on substance use and suicide prevention. And again, this is specifically focused on tribal communities. No doubt, lots of opportunities to really explore how are tribal communities approaching these interrelated issues. How do both traditional in the sense of prevention science interventions as well as sort of non-traditional culturally informed interventions, how do they interplay? How do they impact risk among tribal populations? So you can see here, if you live in these areas, these are people in your backyard who are doing stuff every day where you could partner. Or if you have, a very eager PhD student who's looking for a dissertation topic, excellent opportunities. And then we also have a Minority AIDS Initiative program, which focuses on the intersection of substance use and infectious disease, HIV, hepatitis C, et cetera. Again, it's a relatively small program, but it has been doing some really cool stuff, in particular focusing on communities that historically have been very hard to reach through prevention navigators, other prevention interventions. We are doing an evaluation of all of these programs that I'm talking about. but it's sort of an Uber evaluation overall. But really looking at the more localized efforts is something we hope to do in the future and hope to partner with NIDA to advance that. But again, these are local grantees who are doing, we hope, really great stuff, but we don't always know, and there's an opportunity to study those. So from where I sit, this is sort of my charge to you all as researchers. The things that I think there are opportunities to further investigate. So the big one for me is that we do have a very strong base of prevention science, but there are fair questions about whether or not that still holds in 2024 in a very different drug market, in a different policy environment, in a different political environment. What are the things that we should lean in on? What are the things that we might not want to continue doing? Where do we need to make adaptations to meet the current moment? And then really a need to study that foundational work in different contexts, in different populations, with different family composition, different socioeconomics. Sort of from an internal policy perspective, like what is the right balance by trying to support innovation, adaptations, and doing what we know works? This is like an ongoing conversation as we write funding announcements. How do we encourage people to take what we know works, but make sure that it is applicable and resonant with the community in which it is being operated? But there is likely a scenario where we go too far with that, and people are just doing whatever they want. And I have been in many places traveling around the country where people pull me aside and they say, we're doing this really cool thing. It is so amazing. It's so impactful. I'm like, okay, tell me about it. How do you know? Well, it just feels right. Like, we just know it's right. Okay, I'm not sure on that. Let's study it. But there is a lot of that in the prevention space in particular, where it's sort of like, we are going to bring the most impactful speaker to a high school gymnasium, and that is going to change everybody's life trajectory forever. And that's what we're doubling down on. Like, okay, show me the evidence. But we want to think about how do we continue to support that innovation or adaptations. Another area where we're wrestling with at SAMHSA, I almost said CDC, at SAMHSA, because that was where I was before, is approaching community-defined evidence. So the field feels very strongly that there are things that they have been doing that are effective, but they're not in peer-reviewed papers. They've not been studied in randomized or quasi-experimental studies, but they do have some data to support that they're effective. We really hear this among tribal communities in particular. So how do we best approach that? Like, what's the right mix with other things that we know work? Another area that I really am interested in, and I am definitely a quantitative researcher, but I also have dabbled with qualitative work or mixed methods, which I actually think is the best approach, is really understanding how those decisions are made at a local level. Somebody's writing a grant, and they are weighing what are they going to do? What are the barriers and facilitators to what they do? Not just the implementation side of it, but how do they come to the conclusion that they were going to focus on X, Y, Z program or policy? Really unpacking, like, was it a pragmatic decision? Was it a decision that they had heard about this from somebody else and so that's why they did it? But we often don't know why those decisions are made, but having a better understanding of why those decisions were made, it was a funding issue, it was a resource constraint, it was political, can help us think about how do we better tailor technical assistance to communities? How do we write NOFOs in a different way that allows for addressing some of those barriers or facilitators? Or how do we help educate around the decision-making process on the front end to help communities really match what will likely be most impactful for them to their context? Data capture is a huge issue. Nora talked about it as one of the critical gaps in the prevention space. There are things that we're trying to do at SAMHSA to improve that, but this is a really persistent and almost intractable challenge of having localized data in a timely way to not only inform policy and programmatic decision-making and implementation, but certainly evaluation. And oftentimes people will try to do very strange things with data, like NISDA data at the state level to evaluate a local intervention, which I do not understand at all, but some individuals think that that would be an appropriate thing to do. So I think this is an area where we really want to hear from researchers where has there been success? How do we try to build some of that into our funding announcements or future investments to improve data capture? Because you could have the best research approach, you could have done the best policy and program, but if you have no way to document its impact, or you don't have the resources to do it, we're never going to be able to tell that prevention story. Also, building evaluation and research capacity. So not only do they need data, but oftentimes these are people who are really program folks or policy folks. They don't have that research background, and they often don't have other staff, so they are stretched very, very thin to achieve the things that they're trying to do for their community. And I think this is really where the partnership is so important and where there are so many opportunities for partnership for researchers in those areas to connect with people who are doing the program and policy interventions. And then again, how do we best do that linkage? We hope to, in the future, think through funding announcements or funding strategies that are shared between SAMHSA and NIDA to help do that. But that's not going to solve the problem. We're never going to be resourced sufficiently to match every researcher with a community. So how do we build a culture? Because we're here talking to you today, but in July, we'll be talking to community coalitions, and you won't be there, and they're not here. So how do we think about that cross-collaboration or cross-pollination of bringing those groups together so that we can think about how do we bring this to life? How do we make this operational in communities? And then again, how do we continue to help decision makers widen that lens of prevention? And I'll use a recent research example as something that I have been talking about with behavioral health commissioners in the States and others, like everywhere I go, I talk about this. So recent UNC study, and I don't mean to offend anybody if you're from a different institution, looked at supplemental nutrition assistance program, flexibility and benefits, and compared that with NISDA data at the state level for drug use disorder, substance use, alcohol use disorder. And they found that states that had more flexibility had lower rates of substance use disorder and substance use. And I use that as a way to say most people don't think of SNAP benefits as a substance use prevention policy. But in fact, it can be, because you're addressing some of those root drivers, the economic insecurity, food insecurity, the instability in a family that leads to stress that can then play out in different negative ways. We also know from prior research that SNAP benefits have a positive effect on reducing child maltreatment or child abuse and neglect. So again, it gets back to those shared risk and protective factors, or that sort of risk trajectory of adverse childhood experiences like child abuse and neglect and its connection to increased substance use risk. But when I talk to behavioral health commissioners, like, that's not on their list. They're not thinking about how are they engaging with their state counterparts, because it doesn't sit under them. So it gets to the partnership piece, but it was an important piece of research. We see the same for earned income tax credit, child tax credit, either directly or indirectly linked to reducing risk or promoting protective factors for substance use. We need more research like that to make it tangible as here's a concrete policy change that you can put in place that will help address the political concern you have, which is rising overdose rates in your state, or rising concerns about substance use related harms. Same for program, like, we need to continue to build the evidence base for prevention programs, and then really looking at it in a holistic way. How do you have those multiple layers of research? That's not easy research to do. It gets very complicated. People have taken a shotgun approach. That's been one of the challenges in the opioid space, is that so much was done at the same time that our methodologies are not well equipped to try to figure out, was it all of it together? Was it 2 of the 5 things? And which one contributed the most? So developing new methodologies and approaches, helping us cultivate data streams that can bring that advanced science to the policy conversation. As Nora mentioned, how do we leverage and build up that science, but translate it in a way that speaks to the people who are making the decisions, so funding resources or which programs and policies to pursue. So you guys have just gotten a long list of work that you have to do following this meeting. Immediately after this meeting, I expect you to get on that. But please see us as a partner in this. We are not just a group of people who give out funding announcements and provide funding to states. We want to be data-driven. We want to be innovative. We want to continue to work with researchers, both at the federal level, but also at the community level, to build that evidence base, to translate that evidence base, and then to take from the work that you're doing and make it tangible and actionable for our communities, so that your great work doesn't sit on a shelf. I said shit on a shelf. Sit on a shelf, but it actually is implemented in communities. See, I'm on the decline, right? So like 30 minutes and my stimulants are wearing off, right? So this is how we're thinking about this collaboration, in particular with NIDA. Again, connecting grantees with interventions. There's low-hanging fruit here, right? What's the pipeline of like the latest research that we're then communicating to our grantees, and how do we make that actionable? Connecting researchers, again, with promising interventions, or who are those grantees that are really ready and ripe for research? They just need that support from researchers. Again, studying new contexts and understanding the prevention science base in 2024, and then building that community level research capacity and partnerships. So really appreciate the opportunity. Hope you have some great questions. Thanks again, Nora, for setting it up, and appreciate the time to be with you today. Thank you.
Thank you so much. We do have a couple minutes for questions. We can take it from the live streaming audience as well. I know someone's monitoring the chat. If you have a question, you can walk up to the microphone as well. Okay, go ahead.
Hi. So this question is directed at Captain Christopher Jones. Thank you so much for your presentation. I'm from the Washington State Healthcare Authority. Thank you so much for the SAMHSA funding. You mentioned two things that excited me in state level prevention. One, the interconnectedness of mental health and substance use prevention, and the gap in prevention services from initiation to the development of substance use disorder. And so I'm wondering if there are any advances being made to relax some of the funding requirements for the prevention arm of the SUPTERS block grant, or state opioid response funding, or the Partnerships for Success funding towards mental health and selective and indicated prevention. We've come across barriers using our funds towards these ends, needing to focus mostly on primary prevention and substances, and our community grantees are frustrated that we've had to turn them away sometimes. So.
Thank you very much. And fortunately, Sarah Mariani, your NPN, is on our advisory committee at CSAP, so we get lots of opportunities to hear about the great work happening in Washington State. So a couple of things. I think a point of clarification on the block grant is that the block grant is not, while it may often use the term primary prevention, in statute that means not just universal, but selective and indicated. And in fact, I was just reviewing the next block grant application, and I made footnotes where I specifically said that, so there would be no confusion on that point. The block grant is codified pretty tightly with the prevention set aside. So, within those three IOM categories, you can generally do the things that you need to do. We also did provide some flexibility a couple of years ago by issuing a letter that you don't have to focus on all 6 of the particular required strategies, that you could focus on at least one. This is an area where actually Ingrid and her team, we've been trying to understand, like, that's a policy change. Did it result in what we wanted it to do? Because I think that it could be viewed in both ways, right? So you could say that requiring you to do all 6 with the limited amount of money that's in the prevention set aside means that you might just sort of half-ass all 6, and you don't need to invest in certain ones because you have resources and other ways to invest in those. So you could actually, with the flexibility, really invest in other areas more. But it also means that you could put all of your eggs in one basket. And what is like the least burdensome way to spend down those dollars, but maybe not the most effective way. So we want to look at the mix of, environmental strategies versus education and raising awareness and alternatives.
to see, like, how has this policy change affected what people are doing. On SOAR, it similarly is in statute sort of how the money can be spent. It's opioids and or stimulants, but prevention is a part of that. So you can, and there's no limit, ceiling or floor within SOAR, although I would say it has historically been much more geared towards the treatment side, but states are spending money on the treatment side. So on PFS, we do include both substance use prevention and mental health promotion in the funding announcement, and that's new as a couple of years ago. So we are trying to build in that flexibility, but my perspective on it is that the actual interventions, whether it's programs or policy, like you could label it mental health promotion or substance use prevention, but it's really addressing those underlying risk and protective factors. So my feeling is we should have some flexibility in how we label it, but if it's achieving the goals that we want it to achieve, I think that flexibility should be there. So if there are specifics where like you've really been denied something, I would love to hear about it just to see, was that appropriate or could we provide flexibility?
Technically, we are at the end of time, and I don't see anybody standing at the mic. So I'm going to say, let's thank our speakers again so much.